Welcome to the 2024 Sizzling Summer Series, sponsored by the University of Nebraska Medical Center, College of Public Health, Office of Public Health Practice, in partnership with the Midwest Public Health Training Center. My name is Brandon Drews. I'm the Workforce Development and Leadership Program Manager at UNMC. My colleague Jessica Chavez-Thompson and I will be your hosts for the series. Our sixth annual Sizzling Summer Series continues from last year's focus on exploring how to make data come alive. Now, more than ever, we are called to clearly communicate the invaluable impact of our field through data visualization. Over the months of June, July, and August, we have hosted a three-part series from experts as we continue to build, stretch, and refine our skills to communicate the value of public health through data visualization. To mark our third session of today, we have an insightful presentation from Hannah Ostheimer and Dr. Karen Errichetti on how to use advancing health equity through data visualization. A little background on our speakers. Hannah is an experienced public health professional with experience in prevention program planning with a health equity lens and a passion for public health workforce development. As the principal consultant of Herald LLC, she provides technical assistance and support to state and national public health organizations through training, curriculum design, and other workforce capacity building efforts. She is the founder of the Public Health Training Academy, an organization that provides ongoing continuing education opportunities for public health professionals. Prior to consulting, Hannah worked in both public and private sectors, including roles at state and local health departments, community health centers, and private health care organizations. Karen is an experienced program evaluator specializing in data visualization. She is an expert in public health department accreditation and improvement planning. She is also a leader of health services, management, and policy for the MPH program at Tufts University School of Medicine and teaches master-level courses on program evaluation, public health assessment, and healthcare organization and finance. A working program evaluator, she has assisted several state health departments in developing and implementing equity-aligned health assessment and improved planning process for Massachusetts, Connecticut, and the U.S. Virgin Islands. She has health equity data visualization training for professionals and organizations along with universities. Thank you, Hannah and Karen, for joining us today. We have just a few housekeeping items before we turn it over to Hannah and Karen. For today's webinar, all participants will remain muted. However, we do encourage questions and dialogue in the chat box. There will be time for participants' Q&A at the end of the webinar. My colleague and I will monitor the chat to ensure our speakers hear the questions today. Today's session is being recorded, and the recording and slides will be available on our website. We also invite you to evaluate your experience via a short survey. The link to the survey will be provided following the webinar. At this time, we'll turn over to our speakers.
Great. Thank you so much, Brandon, for those introductions. I'm Karen Errichetti, and I'm going to kick us off here. Welcome to this, and I guess now third webinar in this series, and we're so excited to be able to share with you some of our lessons learned as practitioners in this field of health equity data visualization. As Brandon mentioned, there are a couple housekeeping pieces, but we also wanted to just iterate, if there's a way that we can address you, feel free to change your name and pronouns using the Zoom feature to rename yourself in the participant box. And we welcome questions in the chat box. We will be monitoring that throughout. And we'll also have a Q&A session at the end. So feel free to hold your questions until that time. And again, this is us. Hannah and I have been working together on data visualization training for quite some time. Everyone should have a data visualization bestie, and that is, we are it. We enjoy sharing our adventures in data visualization with practitioners and people from across a lot of different fields in healthcare, public health specifically, but outside in the social service realm as well. And we invite you again to ask questions as you have them, particularly if you have a practice-related question. We love those. This is an overview of what we're going to cover today. I'm first going to start us off with making a case for health equity when sharing information visually. And then Hannah's going to take over and talk a little bit about the strategies that you can use to have more equitable data visualization practice. And we're just going to share what we think are our best practices. There are so many to share. And again, we invite you to share your experiences in the chat box as we go through them. And then finally, we're going to round up with a discussion around equity through accessibility. Accessibility is the ground zero of all health equity work and data visualization. And we're going to share some tools and practices with you in that space. All right. So these are our objectives for today. By the end of the session, you should be able to understand how data visualizations can be used to support or, in some cases, harm progress toward health equity. In public health, we talk a lot about health equity being the center of all things that we do. We're really going to talk about centering that in our visualization strategy. Second, you should be able to recognize the public health responsibility of accurately and equitably communicating health disparity and inequity data, which are not necessarily the same thing. And we're going to clarify what we mean by that today. And finally, you should be able to identify how to balance the principles of design with the equitable use of things like colors, icons, and other visual elements that we commonly see in data visualization. So let's get started. So I want to just start with brief definitions. I'm imagining most of you have attended or thought about how to define health equity in your own work. But Hannah and I really like this definition from the WHO, where health equity is defined as the absence of unfair and avoidable or remediable differences in health among population groups defined socially, economically, demographically, or geographically. And if you haven't seen visuals like these on the screen before, just in a nutshell, health equity is about those things that can drive differences between groups that are unfair. And I work in public health, so I always think in terms of social determinants of health, commercial, political determinants of health that drive differences that all things equal, you wouldn't necessarily see. The example I often give in my classroom is on health insurance. You can give everybody health insurance, but if you don't have all the same drivers at the beginning and you're experiencing challenges in terms of poverty, if you lack transportation or if you lack childcare, you may not be able to access the health insurance benefit that you have simply because of these other drivers. And so when we are moving toward equity, we're trying to address those structural barriers that prevent people from achieving their optimal health. So do health disparities, which is another word we commonly hear in health equity work, equal inequity? Actually, they don't. I think sometimes we use disparities and inequities interchangeably when in fact they are very different things. And we're trying to illustrate that in these two graphs. So let's really start to look at data visualization and what they tell us. So on the left side, you'll see death rates by a 10-year age group in 1 year, okay? And this graph shows us, again, differences across these different groupings of age. But age isn't necessarily a driver of unjust or unfair differences in death rates. So there are other reasons why we see higher deaths among older adults than we do in other categories. On the right side, we see a clear difference in terms of death rates by race ethnicity for a particular year, in this case, diabetes-associated death rates. And this is a clear case of inequity. The right side shows all things equitable death rates, that should be similar across groups, but they're not, which calls the question there might be unfair and unjust things going on to drive some of those differences. And so again, disparities shows us that difference between groups, which may or may not be inequitable. And with data visualization, we can use that tool of sharing information visually to actually describe for people and help them understand what's an inequity and what's a disparity. So case in point, in this example, we're going to show you how data visualization can help us better understand complex relationships and influences which contribute to health inequity. This comes from the Vermont Department of Health, where I actually have a friend who created some of these graphics for their health assessment. And maps are a fantastic way to actually show the difference across groups in terms of geographical zip code or any other kind of geographical information. So here, what we want to share is that there are environmental conditions that exist across the entire state. And we're looking at medication adherence among adults by town. And so there are lots of different things that could actually influence the access that people have to their medication so that they're able to be adherent. And environmental conditions can drive that. So we can look at things like weather or simply the location where you are or the access that people have to pharmacy as shown by the graph on the right. So we start to break down some of the reasons that drive access, differential access across groups, and some of those are driven by things that are inequitable. In this second example, what we're trying to share is, again, another strategy of using your visuals to convey what is inequitable. Data visualization is a very powerful tool, and it can help us compare disparities across different factors or demographics to identify areas of greatest potential or benefit for intervention. And it can help us ask questions like, what are the things that drive the differences that we're seeing? So here we have a lot of different demographic variables like gender, educational and attainment, poverty level, I'm sorry, not poverty, income level, and age. And we can see with the concentric circles, what are the biggest areas that drive access to, in this case, annual dental visitation in Kentucky. And we can see two things that emerge outside of that dotted line, which are educational attainment and our income level. And so this, again, can be used to identify areas where inequities are emerging. And when you add that with trend data and looking at over time, you get powerful data that can tell you not only what the problem is, but where it occurs and what drives it. And that is really the power of using visuals to do public health work. So I wanted to leave this discussion question on the slide here and have you ponder this for a second. And if you feel comfortable here or throughout our presentation, please feel free to share your thoughts in the chat box. Is data inherently objective? Is data inherently objective? What do you think? Feel free to pop your answer in the chat box. I'm seeing some trends in the chat box already, but don't be influenced by those trends. If you feel like saying the opposite, that's okay too. Or if you don't know, that's fine. Okay. Some really great comments in the chat emerging. All right. So I'm seeing a trend of no. In fact, most people are sharing no. I love these comments that folks have made about why. Just gonna, and if I butcher your name, I really apologize for that. As I go through here, I might miss your comment as well. So I'm just gonna pick a couple of these out. So Jean mentioned that I think it depends on where the data comes from. Interesting. Rachel mentioned the data can also help provide a story, but it's subjective to the person telling it. So again, it's not just the data itself, but potentially the source of the data might not be objective. Does that change the quality of that data? Maureen made a comment, no, it depends on what questions were asked, how they were asked, how the variables were categorized, etc. Okay, this is great. Thank you for those comments. So often when we share this question for discussion, we do get the yes and no, which ends up being no with an asterisk. And often when we think about data that we collect, particularly when we collect quantitative data, we feel that there's an objective piece to that. This comes from a very positivist framework of thinking, where there is an objective truth that you can identify because it exists. So if we measure it the right way, we can get to that truth objectively. But what about qualitative data? So I collect a fair amount of qualitative data as a researcher, and I try to represent the lived experience of people. And I imagine many of you on this webinar do, in fact, collect qualitative data. Is that inherently objective or not? And we think of qualitative data typically as not objective, but it's more filtered through the eyes of the person that shared that information about themselves. And it can go, and it also can be interpreted by the person, as correctly pointed out in the chat, by the person who's actually interpreting that data. So taking that in and then interpreting it through their own lens. So data itself depending on your worldview, can be objective or subjective. But when we visualize this information, we also have to consider how we share that information and how we're going to get it out there into the world and how people see information. So thank you for participating in that discussion. So I want to make the case now for data visualization itself and why we think about health equity and data visualization together. And I often share this particular example from the veterinary space where I do a fair amount of work so that we can all kind of have a discussion about this without thinking about human beings. I think sometimes that takes the pressure off of thinking about equity. So can data visualization itself be harmful? So in this example, I'm showing an infographic that comes from the American Veterinary Medical Association that discusses the public health problem of dog attacks. It talks about the magnitude of dogs that exist in the United States, the number of percentage of homes that have at least one dog, which I think is around the 50% mark in general in the US. And that children are the most common victims of dog bites and are also far likely to be severely injured by dogs. And it also tells us the magnitude of the number of bites that have occurred by sharing the number of people who have been bitten every year. So I'm making the case now with this visual that this is in fact a public health problem. So can it be harmful to display information in this way? So the answer to this is yes, and I'm going to try to convince you in a second here, but I want to ask this question to all of you. In the public policy debate around dogs, since we all interact with dogs almost every day of our life, we might see one outside and be thinking about this. The attention is focused on dog breed. Do you know why we talk about dog breed and dog attacks? What do we think here? So we think about dog breed because we hear about it and we quantify this public health problem, typically because we talk about the breed being associated with dog attacks. And you might see visuals like this on the right, which show us dog attack statistics by breed. This is, again, an infographic you might see on the internet, but it very much firmly tells us that the problem is breed specific, and specifically that pit bulls commit the most attacks in the United States. And we also see this in the news, where we often see sensational headlines about true things that have happened to people. I don't want to negate the fact that this problem actually occurs, but it tells us very specifically that pit bulls are the problem. Okay, and all these other breeds too are very much in the running in terms of causing the problem. So we address that problem by taking on policy as a way to address the problem. And it's driven by states assessing the problem and thinking about how can we fix this? Well, if pit bulls are the problem, we're going to prohibit them. We're in fact going to ban them. It's not universal in the United States, where pit bulls and other breeds like them are prohibited from existing, and you're prohibited from owning them. But this is really the policy solution that has been pursued. But what if our data visualizations, like the one I showed you with the big red pit bull on the screen, actually missed the problem? And this is true. According to the AVMA, any dog can bite regardless of breed. The data actually do not back up the fact that the problem is a pit bull problem, but public opinion has decided that it is. And then when we actually look at data about whether dog attacks are decreasing on the basis of these bans, they in fact don't actually bear that out. And when President Obama was tackling this very topic when he was president, he mentioned in one of his speeches that research shows that bans on certain types of dogs are largely ineffective and often a waste of public resources. So I share this example because when we perceive a problem and we perceive the wrong problem influenced by how we visualize information, we get the wrong policy, or at least the misaligned policy, and this causes societal harm. In that, we haven't fixed the problem. We also cause people to believe things that are not true. For example, folks on the left here on what used to be Twitter have discussed how they would love to live in a world without dogs, and other people don't like that kind of comment, but it has actually caused people harm in that their dogs have either been taken away or destroyed on the basis of the fact that they are in a certain breed category. This doesn't fit the problem, and the visuals drive it. We are misusing the opportunity to actually correct a public health problem. So there's a better way to do this and to actually make visuals that drive home the point that we need to make to design public health interventions. I also want to visit this, as many of you on the call are data visualization folks, and there is a life cycle to collecting data. Every project we do involves a lot of steps, and we think about presenting our data. We start with a plan, we acquire that information, we maintain the data in a database, we provide access to that information, and make visuals out of it. We should consider equity throughout the life cycle of how we collect data. We don't collect the right data, we won't be able to answer the very important public policy questions that we have. And we'll end up with issues where we misidentify the problem in the example I previously gave. There are frameworks to actually think about this even more deeply. And when we think about equity, it's not just in making the visuals, it's creating the data itself. The We All Count initiative actually created this data equity framework that allows us to think about the different stages of collecting data and analyzing and interpreting data so that we don't make the kinds of mistakes that we often see when equity is not applied. For example, what are the funders' objectives in collecting information? What is their motivation for collecting it, and why are they doing it? What do they hope to achieve? How do we design our research questions and our data collection strategies so that we collect data that's equitable and actually help us identify points of leverage or intervention? And this also translates to our analysis and how we interpret data, and then how we distribute it to the wider public. So I would like to turn to my partner, Hannah, to share with you some strategies of how you can put equity forward in your data visualization practice. Hannah?
Thank you, Karen. So first, I'd like to share that a lot of the strategies we'll be going over today do come from an evidence base. There's an evidence-based guide for applying equity to data visualizations. This guide is called the Do No Harm Guide, was developed with a focus on how we as data practitioners, whether you're creating the data, evaluating the data, sharing and communicating the data, but how we can approach our work through a lens of diversity, equity, and inclusion. So I'd like to encourage everyone, if you'd like more resources on this, please check out this guide. It is free and downloadable online. So I'll just summarize some of the strategies we'll be reviewing today. I've kind of lumped them into about 5 recommendations here. First is that titles, text, and labels are one of the first things scanned on a data visual. There's actually been eye tracking studies done on this where they present data visuals and monitor the eye movements of participants. And the first thing eyes are drawn to are those words. So we need to be very careful and aware of those words and what language we're using on our data visuals. We also want to take caution when comparing to the norm. How are we framing our data? Where are we positioning groups against each other? Colors and imagery, those are a very important part of our data visual, right? They're made up of colors, components, perhaps icons or other images. And those can be very helpful in translating and communicating our data, but they can also be harmful. We want to be careful about how we're ordering and grouping our data. And then kind of in summary, as we're putting together a data visual, we want to center empathy. Remember that a data visual is made up of data points that represent real people. So we want to place ourselves in the perspective of one of those data points. So I'll start with a recommendation of using people-first language. As a general rule in our visuals, we want to use people-first language. In other words, we want to avoid dehumanizing language. As we're referring to people, we want to reference their experiences, not their skin color or statistics, right? We don't want to refer to a person only by their disease, only by their situation or scenario, their life event. So there's a few examples here, right? Rather than referring to someone as Black or a population group as Black, they are Black people. They are people with a particular trait. Rather than a population group being disabled, they are more than just that disability status. They are people with disabilities. Instead of inmates, we could say incarcerated people, or instead of a diabetic, reducing someone just to that disease, they're a person or a group of people with diabetes. However, there is a best practice. You want to always check with the community. So an example of this that's kind of contrary to those previous examples is using the term deaf or hard of hearing versus people with a hearing impairment. In this situation, individuals who are deaf or hard of hearing consider the term hearing impairment to be highly offensive in many communities because it establishes the norm as someone who can hear and then kind of puts them into a more negative category as being impaired in some way. So in this situation, deaf or hard of hearing is the more appropriate term. So that's why I always say to engage the community, really seek out the community that you are describing or working with in your data visual and use them as the experts on how they'd like to be referred to. The words we choose when sharing information about population groups are important. I've got 4 different words here I'll have Karen put on the screen. And I'd like to encourage you to kind of reflect quickly to yourself what comes to mind when you hear these words, right? So we have vulnerable, we have marginal, burden, and disparate. And just kind of think, with these words, what sort of theme do you get? What sort of tone do they have, right? Usually when I ask an audience this, they're pretty negative, right? And other words that people might think of are weak or less than, right? Disadvantaged. I love that. See some more in the chat. But overall, there's not a very positive feel to these words. So thinking about the negativity that might come with these words, we want to think about the adjectives that we're using to describe populations. And another recommendation for health equity is to avoid stigmatizing adjectives. So I have a slide here that kind of gives a few examples of some of the adjectives we see a lot in public health, right? We refer to populations as vulnerable populations. But rather than describing them as vulnerable, which is kind of weaker or less than, what is it that has made them more vulnerable to a disease or an outcome, right? Have they been socially made vulnerable, perhaps through social structures, institutional racism, economic environments? Or the term at-risk group. Think about the word at-risk youth or the term at-risk youth, right? When you hear at-risk youth, it's not a positive connotation. A lot of times people think, oh, well, they're participating in risky behaviors and activities. But what is it that they are at risk of? Instead of saying they're an at-risk group, they're a group with a higher risk of something. Instead of a marginalized community, perhaps they've been historically marginalized, and we want to focus on that. What is the experience that has led to this? Why is that group more affected than others? So I've got a few more examples here. But just consider those adjectives that we're using to refer to populations. And instead of stigmatizing them with an adjective, let's focus instead on the experience, the history, the social determinant of health that perhaps has led to a disparity or their current environment or situation. So I'll just put this up on the screen here. I'd like to give everyone an opportunity to reflect, right? Think about what language are you using in your work? A lot of those adjectives I put up on the previous slide are very common adjectives in public health, right? It's something that we see everywhere. And so what language do you use in your work? And thinking about that person first language or stigmatizing language, what improvements could you make? And I'll encourage everyone throughout this presentation to start thinking about some actionable ways you could apply some of these strategies to your work. So the next slide here, I want to give an example of some people first language. So this image on the left is a chart that was shared by Vox. They're an American news and opinion website. According to their own words, they say that their editorial networks ignite conversations and influence culture. So in this chart on the left, they use the terms overweight, obese, and extremely obese. Now, those are medical terms that have a very specific defined weight class that fit into the overweight class, obese class, and then perhaps extremely obese or morbidly obese is another one we hear. But by using those words, we're reducing a person to only their weight by saying it's an obese man. That man is a lot more than just his weight. So this chart on the right is a little bit improved, right? Instead of using the word obese man, it's been adjusted to reflect what the actual BMI is that defines obese. Other options for data label changes you could use in this might be woman or man with overweight status, woman or man with obesity. So you're saying it's a person who has a particular disease, but they are more than just that. I'd like to give another example here. This image is from an interactive Tableau dashboard that showed the relationship between race and poverty in every county. And this particular dashboard was looking specifically at population that identifies as Black. Now you can see the chart that they put here and how they actually labeled these data or these data pieces, right? We have more Black and more poverty. So thinking about that, what changes might you make to that data label, right? What issues do you see with that data label there? And I'd encourage everyone to maybe, if you have thoughts about that, go ahead and put them in the chat. And I do see a note in the chat about health literacy and how BMI may not be understood as a term with the general public. I do want to address that because that is a very good point. Maybe, Karen, can you go back to that slide? So looking at that chart, one of the benefits of data visualizations is that we have that visual to kind of add to our understanding, right? So even if we do change the data labels to BMI, the title of this chart still uses the term obesity. And in this context, we're not reducing a person just to that status, right? We're saying the stunning rise of obesity in America. So we're still explaining that obesity is rising and growing. And then our data labels are also showing that upward trend. And so that upward trend is also a visual that can help a person with their understanding. So that's a very good point about considering health literacy there, because someone may not understand what a BMI range is. However, paired with other components of our data visual, we're still showing that upward trend and that title explaining this is obesity and obesity is going up. So there is a balance there, and it is tricky finding that balance between getting our point across while still using equitable language. Thank you for going back to that. So again, this is another great example of kind of some challenges we see with the labels that we're using. More Black, does that indicate perhaps a skin color that's darker than someone else's, or does that indicate a greater density in that population group? So this is just another example of some language that could be improved in this visual. In the interest of time, I'm just going to keep going here to our next suggestion. So comparisons and the norm. Oftentimes we're comparing different population groups in our data visuals, right? We're comparing between age demographic, we're comparing between race or ethnicity, between geographic location, between income level, education attainment. We have to be very careful about how we're framing these, because if we're comparing populations, there's a risk that we're framing one population as the norm, right? When we want to make comparisons, we should be comparing to the ideal scenario rather than the best. And I'll expand a little bit on this, but if we pick one population group and we kind of put them up on this podium as the best, we could be framing them as the norm and establishing some relative status differences between population groups. There's a lot of statistical methods out there, particularly those that are looking at racial and ethnic differences that perpetuate white supremacy, right? In the common approach of identifying reference groups, we often frame white populations as the norm or the standard, which is implicitly circumscribing what's possible for other groups, putting a white lens over it. And there's a lot of studies that have shown that the way in which we present risk or frame risk can affect perceptions and judgments. So here's an example. This is a table that was published in a morbidity and mortality weekly report by CDC. And if you click one more time, I'll highlight a couple of boxes there. You can see in this table that they created a disparity ratio between all racial ethnic groups and the white population. So they compared Black to white, American Indian Alaska Native to white, Pacific Islander to white, and Hispanic to white. However, what do you notice about this? Was the white population group even the best comparatively out of all of these? right? They had a mortality ratio or mortality rate of 12.7, whereas if we look at Hispanic populations, they had a mortality rate of 11.5. They were actually comparatively the better outcome group. So why are we comparing to the white population and kind of framing them as the norm when they weren't even the population group with the best outcomes? And so this comparison here is implicitly restricting what's possible for other racial or ethnic groups. So I'd like to pose a question. Again, if you have a thought on this that you'd like to add to the chat box, please go ahead. But what are other comparisons that we could possibly do that still add value to this analysis and the understanding of the data without framing one population group as the norm or the best? Yeah, so here's one. Maybe white is not the norm, but the majority of the population. So that is true. And one of the things we have to consider is that part of the story behind our data, right? Are we talking about differences based on population size? Another comparison we could possibly do is framing to the ideal. Ideally, it's 0, right? But we know that that's not attainable in public health. That perfect number, we strive for it, but it's not a possibility in most scenarios. So maybe we could compare to like the global ideal, perhaps pregnancy-related mortality rates in other countries like Norway, Italy, Poland, right? Those countries that have these incredible outcomes in terms of pregnancy-related mortality. Perhaps we could compare to the average rather than a best. However, we want to be careful of that again, because then that can frame some populations as better than and some populations as worse than. Another comparison or possibility is healthy people objectives. Do we have a goal that we've established that we want to compare to? So those are all kind of suggestions of how we could possibly frame the norm or comparisons differently that don't implicitly limit or make one population group better or worse than others. So another equity problem that we see with data visualization is misrepresentation of the data. So looking at this chart, this is a chart showing Oregon adults who have visited a dentist in the past year by race or ethnicity. In this example, we see some really big differences, right? It appears that the white population group has visited a dentist almost twice as often as a Black or other population group. But if you look at the y-axis, it's been truncated. That only goes from 55 to 75% on the left. It falsely makes it appear as if certain population groups are receiving dental care significantly more or less than others. If we look at this improved graph now, we've redone this with a complete y-axis of 0 to 100%. This more accurately displays the disparities between population groups, that they are still present. There are still some disparities, but they're significantly lesser than the chart on the left makes them appear. Now, a lot of times the feedback is, well, now viewers can't really clearly see the differences, and we're trying to demonstrate these differences, and they're not as visible on the chart on the right. If this is the response, then perhaps a different type of visualization is needed. Perhaps we need to look at another way to display this data that allows us to see those differences without misrepresenting them to be more than they are. Now let's talk about color choice. Colors can be harmful or helpful. Certain colors do reinforce gender or racial stereotypes, right? You think about blue and pink. Everyone goes to male and female for that. Color schemes can also imply bad versus good or worse versus better. We use a lot of graduated color palettes in certain data visualizations, going from red to blue or light to dark, and those have some meaning behind them. So let's look at an example. This color palette on the left comes from a MIT diversity dashboard. And as you can see, almost every racial group was represented with shades of red, except for white. The white population group is blue, and almost every other is red, right? If you think about colors and the meanings, red often has a negative feel. Why was the white population group so distinctly separated? And then why are international and unknown kind of the shade of gray? Now, MIT did update this, and when they updated it, they improved the color palette a little bit. They shifted it to include a greater variety of colors and not ostracize one group so specifically from all of the others. So you can see how they've improved this a little bit. It's still not perfect, but it doesn't now create such a distinct disparity between whites and non-white population groups. Here's another example of color. BBC during the COVID-19 pandemic, had a dashboard displaying global deaths. And they actually used different colors in this same dashboard, depending on if you accessed it from an English IP address, English-speaking IP address, or located within the United States, and a Chinese IP address. People associate colors with certain emotions, right? We just talked about that a little bit, about red and some of the negativity to the color red. In the United States, red we associate with anger, with hate, with negative things, with bad things. And purple in the US is often associated with pleasure, pride, admiration. However, in China, in a different culture, red signifies positivity. It's kind of a symbol of life-generating energy and prosperity. So red would not be an appropriate color to use to display massive death due to a pandemic, a global pandemic. So you can see how the BBC adjusted their dashboard to be appropriate for the particular viewer or target audience. Now I want to touch on icons and imagery, right? Sometimes we use icons or imagery to supplement our data visualizations. Do our graphics that we're using represent a variety of people? Do they reinforce stereotypes? How might our graphics be perceived by our target population? I'll give an example here. I have two different screenshots here showing the Google search when you search teacher icon and professor icon. And actually on the next slide, I made these a little bit bigger so it's easier for everyone to see them. But looking at these, let's say you had a data visualization on teachers or professors or something educational. What themes do you notice about these icons? And feel free to type your observations in the chat. Gender, yeah. If we look at the teacher icons, most of the teacher icons that appear to have a gender are female, whereas most of the professor icons that have some sort of obvious gender appear to be male. Color, age, yeah. We see a lot of younger imagery for teachers, and the imagery for professors look older, nearsighted and farsighted, yeah. What about racial or ethnicity representations, racial or ethnic representations? The vast majority of these icons appear to be white if they have some sort of obvious race or ethnicity. So sometimes when we're putting something together, you might do a quick Google search, oh, I need an icon representing this, but be very specific in the selections you make. Because as you can see, there are some biases here in what does a teacher look like? What does a professor look like? And we want to make sure we're being conscious about the graphics and the visuals we're using to prevent furthering stereotypes and causing harm. Here's an example. This actually is an example of many of the different strategies we've discussed so far. This is a tweet, or formerly a tweet on the right, that displays an infographic or a data visualization showing average female height across a number of countries. And the person who shared this tweeted, as an Indian woman, I can confirm that too much of my time is spent hiding behind a rock, praying the terrifying gang of international giant ladies and their Latvian general don't find me. So you can see in this data visual, this Indian woman on the right appears to be about a third or less the size of a Latvian woman. We see multiple issues here. That y-axis is truncated. It starts at 5 foot and goes to 5'7". In reality, that Indian woman is only 5 inches or 5 inches shorter than that 5'5" Latvian woman. But because they truncated the y-axis and then on top of that used icons displaying a full person, they really changed the interpretation of this data. We also have issues with color there, stereotypical colors, stereotypical icons of the woman in the dress. There's quite a few issues with this data visual. With that, I'm going to pass it over to Karen to review a few more recommendations for equitable data visualization.
So there are a few other recommendations that we would like to make for you to consider in how you visualize data. In addition to iconography and color, ordering your data purposefully is a strong recommendation for successful data visualization. It's important to consider if population groups are displaced to the bottom of the lists that you order your data to, or the top. And the order of labels can actually ostracize or put in a position of privilege certain population groups. In the same way that we looked at the example of using white as a reference group in, for example, a regression model or in any kind of visualization, we can have the same effect if we order labels in a certain way. If you order your data according to the community of focus, the story of your data can change. And so we can use things like using alphabetical order or order of magnitude. It's also important to provide options for inclusivity. For example, providing options beyond just male and female for gender, and also being very, very purposeful and careful about using the other category. So I just want to share an example of that here. So on the left side, you can see a data about pregnancy-related deaths per 100,000 live births. And again, this data is a bar graph. And we typically see these types of graphs, and we might overlook them. But what's really interesting about this graph is that white remains at the top. Is white the highest magnitude? No. Is there something special about it that it should be at the top? Not really. So how can we improve this? Because we have, again, underneath all of these other race and ethnicity groups that are not the same in the same order and the same sort of priority. And we typically think of things at the top as being better than things at the bottom. So to improve this, reordering the bars in the bar chart might be a good way to do that. So instead, in this example, we see the first 5 bars are in fact by magnitude. You could also do this by alphabetical order. But given the topic of pregnancy-related deaths, where you might be trying to underscore and sort of see where different groups fall out in terms of the number of deaths per live births, again, this is ordering by the consequence here. And at the bottom, you have a bar that says all women. You may also be able to use color to distinguish things here. For example, all women is exactly equivalent to all the other categories. So it may be appropriate to use a different color there. So you can mix and match strategies that we're sharing, but ordering has to be done purposely. Otherwise, there could be a misunderstanding about the importance. And also for people who actually look at this graph, who find themselves in the graph, do they find themselves in a position where they understand the negative consequence of the data and what it actually says? So this is really just a very basic example of how to do this. I also want to call out the other category. I often collect a lot of data where there's an other box where you can put in what that other category is if it's not represented. It's important to carefully consider how you collect that data and analyze it and communicate it. What is that other group measuring? We have a little snapshot of the other adjective, where we talk about adjectives and the importance of framing words and how we use that in visualizing information. Definition here is disturbingly or threateningly different, alien, or exotic. That's one definition of the word other. And when we other people, which is a way we describe putting people into one category without actually giving name to things, we can miss out a lot of the nuance and interpretation of that data. So again, what is other measuring? It can be an important option for individuals who do not classify themselves within any of the previously listed categories. For example, if you're answering a question about race ethnicity and your category is missing, or you're of mixed race or mixed ethnicity, you might have to be forced to choose the other category. And then we lump all of those folks together and share information about the other category as though all the people in that category are the same. We have to remind ourselves that we're talking about people again who deserve dignity. And when we lump together large groups of people who have significantly varied characteristics or life experiences, we miss the opportunity to learn about them and understand their experiences. Here's another example, of, again, from the race ethnicity space. This is from a faculty diversity dashboard. And I encourage you, if you have a comment in the chat box, to sort of tell us what some other alternatives to the category label of other might be in this visualization. As you can see here, there is other and no response. And so people may not have identified their race or ethnicity for this particular survey. And so this is how they decided to represent this. So going back here. So if you have a comment about this, again, when we have groups where other is represented, there are other ways to do this. One way is to break this down and actually not use a bar chart, but to actually present the other group and explain in qualitative terms what that group represents. There's actually no footnote here telling us what that includes. And I'm seeing in the chat box, the cream color blends into the white and disappears. Right, so the color choice there is also incorrect and leads to misunderstanding. And finally, we just want to cover empathy, since we brought this up as our 5th point in strategy for bringing equity into your data visualizations. Again, put people first. Remember that the data is representing some group, and within that group are people who deserve dignity and respect. How can you present that data where you are empathetic to the fact that these are human beings? It's important to use personal connections to help audiences connect with your data. And so how you present that data has to connect with people and tell some kind of story about them. Again, they are not survey data, they are real people. We often find it's really effective to combine both qualitative and quantitative approaches in visualizing data. Instead of objectively putting people in bar graphs, sometimes it might be important to actually share information that people provide, like in a call-out bubble, to explain how people responded when they actually put in their other. We want to also support engagement of communities in helping construct how they are visually represented in their data. It's important to go back to the community and say, how do you want to be represented? What label should we use? There are many organizations that have actually come up with ways to label specific groups. So you can rely on some of those organizations to do that. And Hannah's also put into the chat some possible alternatives to other that you might be able to use in your work. Also consider about how framing and the words you use could lead to a biased emotional response, or any response that might be negative about learning from the data. If you're presenting data that it's important to develop a new intervention or to inform policy making, your data, if presented in a way that doesn't center empathy, could be misinterpreted or, at worst, not used in the way you intended. Also recognize the needs of your audience. All audiences are different. Not everyone needs a dashboard. Not everyone needs, an animated graphic or something of that sort. And it's also important to acknowledge the histories of racism, injustice, and abuse and discrimination that serve as the background for issues that we study and practice every day. And if we can sort of acknowledge that and in our visualizations, pull some of that out, we are going to be far more successful in communicating the stories we want to communicate with our data. And I'm just going to skip this for the interest of time, but if you do want to reflect on some of the things that we have shared today, I strongly encourage you to think about health equity and how it figures into your own work and where you may have the potential to do the most harm with your data visualizations. I'm going to pass this back to Hannah to round us out with a discussion around accessibility and equity.
Thank you, Karen. So I know I watched the previous webinars from this series, and I know accessibility was touched on, so I won't spend a lot of time on it repeating what you've already been told. I just wanted to share some resources. So when considering color, there's a fine balance between color that actually displays the various categories that we need, color that is equitable, and color that is accessible. So Color Brewer 2.0 is one of the tools out there that can help you come up with sequential or diverging color series that are also colorblind safe, print friendly, photocopy safe. How often do you see a report that's a photocopy of a photocopy of a photocopy, right? So that's a tool I wanted to share. Another one is Coblis. This is a color blindness simulator. So you can take an image of your data visual and upload it to Coblis, and then actually see how it appears according to different some of the different types of color blindness, right? So this is an image that was uploaded. And if you go to the next slide, this is what the image appears like when you apply a form of red-green color blindness to it, right? You can see those categories blending together. So I highly recommend checking your data visuals using tools like this. Color contrast is also an important thing, making sure that we have enough contrast between text and backgrounds to view and be able to read language. So color review is a great tool to check your color contrast. Next is the Web Content Accessibility Guidelines. I know this was touched on in one of the previous presentations, but these are globally recognized accessibility standards that if you have data visuals that will be shared online, I highly recommend working through these standards to ensure your visuals meet these recommendations. Next is alt text. So alt text is a very important piece of your data visual when it's going to be used in a computer or online format. So this is a written description that conveys the meaning. And these are what will be read by a screen reader. So screen readers are used by people who are blind or have limited vision that makes it difficult to read. But screen readers are also used by people in rural frontier areas with slow internet connections, especially in developing countries. If you're working in global health, right? A lot of times they're using alt text because they can't get something to load. So alt text is very important for translating the meaning behind your data visual for someone who may not actually be able to view that data visual. There are also tools out there that can convert charts to tactile graphs printed using an embossing printer. So one of these is HighChart. It's an online tool, and you can actually have your graph converted to something that can be perceived with a sense of touch. Another really cool tool available by HighChart is sonification, and I'll have Karen play this. This converts data points on a graph to audio for people who may not be able to visually interpret a graph.
And I'm going to try to play it, but if you cannot hear it, please let us know in the chat box. We can share the link to this as well.
Japan. Sweden.
I don't think the audio is going through on that.
It's not
So
coming
we'll
out.
No.
We will
we'll
share
move
the link.
forward.
Let's share the link to it.
Yeah, we'll share the link to that. But that's another tool that is a really unique way of translating the data from your visual. And then finally, I wanted to share an accessibility checker called Chartability. This is a set of testable questions to ensure that your data visuals, systems, and interfaces are accessible. It is organized into 7 principles, 4 of which actually align with the principles from the Web Content Accessibility Guidelines, plus a few more. And this is a really great way to actually work through and check accessibility of your data visuals. So I know we don't have much time here. We crammed a lot of information into this presentation. I wanted to leave everyone with the encouragement to come up with a few actions you can take in the next month to apply some new health equity strategies to your data visualization work. With that, I know we have a little bit of time for Q&A. Brandon has a couple messages for you all as well, but I'm sure Karen and I can hang on for additional questions.
Yes, if you have any questions, please feel free to put them in the chat. You'll find that I put some information in the chat for you as well in regards to a survey, give us feedback on today's session. And for those of you that are in Nebraska or will potentially be attending the Nebraska Public Health Conference, there in the chat is also a link for considering submitting an abstract as well. So with that, we're going to see if there's any questions for individuals. I did have one question that was sent to me, and that is, what best practices do you have for testing data visualizations, both among populations of interest and those who are not part of the population of interest, but maybe those who have power or privilege to make changes?
I think for me, that comes down to community engagement, right? As public health practitioners, we're really seeking to transition from informing communities to referring to communities, to engaging with communities throughout the whole process, to empowering those communities. And we're trying to shift towards that ideal end of empowerment. And a lot of that involves engagement with communities from the start of that data life cycle, right, with the planning of the project. Now, that's not always feasible, so bringing a community in whenever possible, as early as you can in that data life cycle, I think is the important piece. Karen, I'd love to hear your feedback as well.
Yeah, I agree with that. And I also want to share, like, there's a danger to tokenize people when you ask them for their feedback to look at your visual, particularly if you go to them all the time. As a faculty member here, I always, I struggle with finding community members sometimes to give me feedback on visuals. And so the next best thing is to find someone who is similar to that community who can represent that. But I have to be very careful not to repeat that too much. There's diversity everywhere, and sometimes it's better to have a plan or to not check and to have folks around you who are working in this space to actually inform it, rather than asking someone who has the characteristic that you're looking for. I work with Spanish-speaking populations a lot, and there's no single person who can represent that. It depends on the context and where you're doing the work. And so it's critical not to tokenize people and put them in a particular box, because it defeats the purpose of what we're doing.
And I do like seeing now that more and more public health programming and projects are expressing thanks for the value of someone's time. So think about, we as public health practitioners who are being paid, however many dollars an hour to do this work. What about the populations you're bringing in and seeking feedback from? Their time is also valuable, and truly you are seeing them as an expert on the same level as you are in the project. They bring a different perspective that is just as valued and needed. So ideally in your projects, ensuring that when you do hold focus groups or survey, ask for survey participation, that you're providing some form of compensation or acknowledgement, for that person's time and expertise and contribution to the project.
Seeing no other questions in the chat or in the Q&A, I want to just take this time to thank both Hannah and Karen for your presentation today, for answering the questions and help us better understand how to advance health equity through data visualization. I want to thank everyone that was able to join today's call, and in advance for completing the survey to give us feedback. We look forward to seeing everyone next year, and have a wonderful day, everyone.